So good evening, everyone. Welcome to the another webinar that we have, came up with in the medical age series. This is again a very interesting topic that we have come up, and this topic we have taken from one of the new textbook that we have recently published. We have with us Dr. Gaurav Desai, who is also author of this book. Dr. Gaurav Desai is assistant professor of Gynaecology, St. GS Medical College and King Edward Memorial Hospital, Mumbai. He is also consultant minimal access and robotic surgeon at PD Hinduja Hospital, Mumbai. So this webinar is basically we're going to discuss this topic, and just to tell you all the attendees that we are also going to have more such webinars under this series. Now I request Dr. Sai to please start the session from his end. Thank you, sir. Please, sir, over to you, sir.
Yeah, thanks. Just trying to share the.
I'll just give you the sharing right, sir. Just give me a second.
Yeah.
Now you can share the document, sir.
Yeah. I click on share and then.
Yes, sir. You share and then you may share your screen also, like, or you may also share the file directly from the source.
How do I do that? I'm not.
Sir, actually, no, you have a sharing right. So just click the button on share, and
Yeah.
when the window opens, there is a file option there you could see.
No, it says open system preferences. Allow WebEx to share your content.
Yes, please go ahead, sir.
So I have allowed it from my end.
Okay, now, sir, no. So once you click the share button, it will open. The window comes and says now that you can share your screen, and you also share some.
No, that window doesn't come. It says allow WebEx to share your content, grant access in system preferences. Open system preferences.
Sir, shall I show the chapter from my end? I can do
Yeah,
that also.
sure. Yeah, do that.
I think that will do. Sure, thanks.
Okay, so good evening, everyone. Thank you for joining in. As was introduced before, I'm actually a minimal access surgeon in Mumbai, India. I'm also a teacher of obstetrics and gynecology at KM Hospital. So over the last decade or so, I have taught quite a few students, but I also do a lot of advanced endoscopy, including oncology and endometriosis in Mumbai. And I have recently got this opportunity to write this book and to actually share my experiences with the students and with the next generation. Uh, so I think this book is basically a mixture of what I have learned and also tips and tricks of clinical obstetrics and gynecology. This book has actually been taken a little over a year. It has an offline or a physical segment, which is the physical book, but also quite a significant online uh, database of multiple choice questions, which are actually interactive and also have detailed answers. So they actually there is a lot of content within the answers itself. And additional to that, there is also online theoretical content and images. So it's quite a significant part of this publication. Can we have the next page? Yeah, so the physical format of the book is what you will see here, and it's got quite a bit of quite a number of topics based on the competencies. Next page. I think we won't spend much time on this. The index is there. I mean, they have it is all up to date. It's got competencies. Yeah, you can go straight away to the chapter, I think. So, one of the chapters that is selected for today's session is on malignancy. And since I was a designated fellow in oncology, I have experience at Tata Memorial Hospital as well as at Amrita Institute in Kochi. So, where I was a dedicated gynec-oncology fellow and also did robotic surgery. So I have a vast amount of experience pertaining to this topic. This is one of the chapters in the textbook. And gynec-oncology is one such topic that has some variations as far as India is also concerned. Just simple variations. For example, in states like Maharashtra, there is a fairly high incidence of CA cervix, which is the predominant malignancy as far as gynec is concerned, especially in the interiors, in the low socioeconomic groups of the state. But once you come to the affluent or higher socioeconomic cities like Mumbai, we see a lot of C endometrium, C ovary. If you look at where I was trained in Amrita Kochi, down south, they have a lot of C endometrium and also C ovary, but quite a bit of C endometrium because of diet, because of maybe genetic factors. The obesity is quite rampant. So whenever that is there, you have high amount of hormones, and that leads to a lot of estrogen and development of these malignancies. Now, apart from this, I was also a postdoctoral fellow in the United States, where I did research on tumor imaging. So there's a vast amount of advances which are going on in cancer, especially in gynec cancers and even other cancers. And this is something that is definitely, uh, it, if it is recognized and diagnosed, it can be easily treated. Uh, Contrary to some decades ago, when not so much knowledge was known about cancer, uh, women used to really die. They were just diagnosed with cancer, and that was like a terminal life sentence. But now with so many advances, there's a lot of interest in gynec oncology, doing degrees in gynec oncology, but also from an examiner point of view, if you are looking from students, examiners love to ask topics related to gynec malignancy. I mean, just recently I was correcting papers for the university exams, and even there, things like abnormal uterine bleeding, you'll asked questions about gynec malignancy. So there is always something which is there. And the thing about gynec malignancy, as far as the exams are concerned, is it's a very scoring topic. Sometimes there are hurdles as far as the staging system is concerned. People can't uh, learn that up. So we'll go through a few of those, and we'll actually see how this book can help in learning gynec malignancy. So we'll start with endometrial cancer. You have a representative image right at the beginning, next page. And after this, we sort of go into the depths of gynec malignancy. Can you switch the page? Hello? Yeah. So you have these classifications of uh, where you have these tables, and if you go through these tables, they sort of are self-explanatory. So you have uh, right after that image, you'll have a very explanatory table about certain characteristics, classifications of endometrial cancer. As you all know, there are type 1 and type 2 uh, uh, varieties of this, and each of these tables describes the histological type, the prevalence, the grade, the tumor location, prognosis, etc. So you have these compared one on one on these parameters, and further there is the various risk factors. So as you all may know that endometrial cancer, estrogen is a very important component of causing endometrial cancer, and all the conditions related to hyperestrogenism are detailed one below the other. So for example, obesity, PCOS, unopposed estrogen and estrogenic ovarian tumor, etc. Now we come to comorbidities like diabetes, the corpus cancer syndrome, or metabolic syndrome. You have genetic basis and others. for example, higher socioeconomics strata, etc. Next page. Then we come to the FIGO classification or the staging systems, and importantly, this the main stages are actually written in bold. Stage 1 is that which is confined to that corpus uteri. Then it is divided into 1A, 1B, so it is less than half of myometrium or more than half. Stage 2 is basically invasion of cervical stroma. Stage 3 is local or regional spread. And stage 4 is invasion of the urinary bladder, bowel, or distant meds. So these are sort of important in a sense that they also give you, one has to know the clinical applications of this endometrial cancer as to what type of management one has to do. So then you have, apart from that, the histopathology, which is important. So endometrioid is one of the prominent types, the papillary, the clear cell, the squamous cell cancers, carcinosarcomas. So I have encountered all these types of, and I'm sharing some of the best cases in this textbook. These are all patients that are operated by me. You also have advances like estrogen receptor, progesterone receptor. Next page, please. Yeah, so the next page, once that is done, you come to the clinical features. So you have abnormal uterine bleeding, foul smelling vaginal discharge, you have signs. So a table which basically will tell you the symptoms the patient will come with, and then the signs like, hypertension, you have high blood pressure, you have pervaginal bleeding, large uterus, like you can have pyometra, myomas. You can also have diagnosis. In the diagnosis itself, there is a table which will show you cytology, which you do in the outpatient department sometimes, like pap smear. You have imaging, which is also done. So transvaginal sonography, an MRI, a CT, a PET CT, and even chest radiography, which you need to rule out metastasis and for fitness for surgery. Hysteroscopy, which is also done, which has either a direct biopsy where you diagnose, take the sampling, and then you take it to diagnose endometrial cancer, and polypectomy, and other investigations which you use mainly for fitness or for operative workup and also for post-operative monitoring. Then, of course, endometrial cancer, it's important also to understand what the histology looks like. And for this reason, I have put histological images of some of my cases in this textbook, and to basically show to give an idea to the reader and to the student as to what exactly is uh, endometrial cancer or any of these types of cancers, because gynec-oncology is one subject where it is not only just a clinical subject, but is also an pathological subject. So you need to actually review what the pathology is under a microscope. Then the next page, please. So after this we have the next page shows the routes of spread. So we discuss about the uh, various ways that endometrial cancer spreads. So of course, direct invasion, like for example, different parts of the uterus, the cervix, the tubes, and even adjacent organs. You have lymphatic metastasis from the iliac groups, common iliac, etc. The hematogenous, that is blood-borne spread, and other types of spread. Then, of course, we also will lead eventually to the management, which is also very important as far as exam point of view. Can we have next page, please? So you have now it's important to know that the standard is of course staging laparotomy now, or a staging laparoscopy or a robotic surgery. So frequently a lot of textbooks give the open laparotomy format, but since I am of course up to date with certain advances as far as endoscopy is concerned, especially robotic surgery, where I myself am practicing doing this. So basically, this is with it is taken side by side, as in it is given equal importance, and in fact, where it is the standard of care, endoscopy is always given above the conventional open surgery. So endometrial cancer is one such malignancy where minimal access, either laparoscopy or robotic surgery, is now routinely being done in some of the best centers in this country and in the world. So this has been given equal importance. And apart from that, we will discuss the steps where I've written the steps of a staging laparoscopic or robotic surgery. So you have all the steps which are required and must be written in the exam. After this, one can actually have detailed discussion as to how long this patient has to be followed up. So all this is given up 1 week, 1 month, 6 monthly, up to a year. Then the indications for a lymphadenectomy. When one does one actually do a lymphadenectomy? So is it important in all the stages, or is it important in certain tumors? So for instance, high grade tumor, if there is spread beyond the uterus, rare types like clear cell papillary carcinosarcoma. Remember, you do omentectomy in only the serous types of endometrial cancer. You don't need to do this in all types of malignancy. The radiation therapy, uh, I have given it specifically in a form of a table format, so it is very easy to remember. It is not something that is rocket science. Important from, because I have personally seen radiation therapy. So vaginal, external radiation, extended radiation, and whole abdomen. So it is given like this: when you do which type, uh, why is it specifically given? So for example, vaginal is reduces vault recurrences. It's important to reduce vault recurrences. External beam, it is reduces pelvic lymph node recurrence. Okay, then extended is for para-aortic, any higher lymph node involvement. And of course, whole abdomen is actually very infrequently done because the side effects are quite a few. Now, you come to chemotherapy and hormonal therapy also, in which types. Can we have the next page, please? And after that, we eventually come to certain prognostic factors, like certain the tumor factors, you have invasion, you have genetic, and you have others. So in this sense, we have sort of covered up endometrial cancer. Next page. Now, when we come to ovarian cancer, this is actually uh, something that is seen very frequently in the city actually where I am from. Uh, and it is the standard of care is, of course, still staging laparotomy. Okay. So it is, of course, the second most common gynec cancer. There are a number of classifications, various risk factors which are involved, which are, some of them are modifiable, non-modifiable. So this is given in a very clear format table. Some, for example, modifiable factors like nulliparity, infertility, things like racial, those fatty diet, things which can be modified, alcohol, hormone replacement, PID, and endometriosis. Those which are non-modifiable, like for example, early menarche, late menopause, age and genetics comes in, and also family. Next page. We come to another histology. Like I said before, with endometrial cancer, even ovarian cancer, uh, one has to know at least what the ovarian cancer looks like. So I've placed a high-grade serous carcinoma picture over here. Important to know the BRCA genes. These are highlighted here, frequently asked. All these are all high-yield facts, which are asked in Viva exams as well as in MCQ format for various exams, not only India, but even in if you have to apply for US or European exams. So protective factors, again, surgical, non-surgical. Important to divide these. It's, if you present it like this, the examiner knows, or the paper checker knows, that one is well versed with this subject. Now, after this, if you look at even histopathology, this is a table that some of my students who have looked at the book uh, have really liked, in the sense that the histopathology, we have actually compared uh, each of these serous, endometrioid, mucinous, clear cell, transitional, all across, compared to each other. So, for example, if you look at the incidence, serous, serous is the commonest, and then you compare the others. If you look at the laterality, you have serous, which is bilateral in half the cases. If you compare it to mucinous, it is unilateral. And if you compare it, say, to transitional, then those are associated with Brenner's tumors. So things like clear cell, which is associated with endometriosis or endometrioid. So these sort of highlighted important facts are actually given very clearly in the table. So in the exam, it's very easy to recall. You compare the consistency, solid, cystic, fleshy for endometrioid. You have septate ones like mucinous. So quite a easy format to learn. Next page. Now again, you have a histopath image of clear cell cancer of the ovary, so that one realizes or recognizes this tumor, because it's not just about learning for the exam. One has to also eventually do it in practice, and especially if you do a gynec-oncology fellowship or a degree, one has to know how this looks like in under the microscope. So you have histological grading, you have FIGO staging of ovarian cancer. So importantly, in the table, ovarian cancer, as you all might have known, it's divided into 4 stages, with stage 1, which is confined to the ovaries, and stage 4, which is distant metastasis. Uh, Again, the substage, there is a second next column, which is in substage of stage 1, for instance, 1A, 1B, 1C. So 1B is tumor limited to one ovary, and that one is actually given in italics because that is important. So one ovary or the fallopian tube without, again in italics, without tumor on the ovary or fallopian tube surface. Okay. Now 1B is tumor on both ovaries. So both is highlighted here. Without tumor on the ovary or the fallopian tube surface. 1C is tumor on one or both ovaries or the fallopian tube with surgical spill, that is 1C1. Capsule ruptured, again 1C2. Malignant cells on the peritoneal wash, so that is 1C3. All these are highlighted and important to know. Then you have stage 2. You again divide into stage 2A and 2B. 2B is extension to other pelvic intraperitoneal structures. So, for instance, if in a question, the question can be framed like, what stage is, what is the treatment for this particular stage where it involves other pelvic intraperitoneal structures. So, the management, it should strike that it is actually stage 2B. Okay. And then you come to the management of stage 2B. Again, stage 3, this similar thing, stage 3, A1, A2, based on the size, less than 10 mm, more than 10 mm, stage 3A2, which is again microscopic extra pelvic. 3B is macroscopic. So, and 3C again is macroscopic, but the peritoneal metastasis is more than 2 centimeters. So these things are highlighted in this table and very easy to learn and recall. Again, inguinal lymph node is again highlighted because this is a question which is asked. It's stage 4B. So although lymphadenectomy is in an earlier stage, inguinal lymph node and lymph node outside the abdominal cavity is stage 4B. So then you come to the symptoms, next page, and you come then to the pathways of spread of ovarian cancer. So in these pathways of spread, you look at all the types of spread: transcelomic, lymphatic, direct, and other routes, just like we did in CA endometrium. Transcelomic is given in the first column because it's the most common way. It's exfoliation of cells. You have transperitoneal spread. There is omentum is the most common. So that is, it's called caking. So these important words are used because these will be frequently used by gynec-oncologists and in residencies, also in exams. Then lymphatics, you have stage 1 and 2 lymph nodes, direct spread to the adjoining organs and other routes of spread also. Okay, then you have the signs. So you have clinical examination, important in practical exams also, where you have to examine a patient with the ovarian mass. So you have Furcow's node, you have breast lump like in Krukenberg's, you have bimanual pelvic exam, which is also given, workup and diagnosis. You have in the workup and diagnosis, you have preoperative workup, you have imaging, you have tumor markers, you have various parameters which are used like ROMA, RMI, ADNEXA. You have interventional imaging like FNAC, ascitic tap, pap smears, endometrial sampling, which is also done in ovarian tumors because you can have a, concomitant or coexisting endometrial malignancy as well. So all these are detailed here. Next page, please. And then we come to the surgical procedure or the staging of ovarian cancer. So this is given in detailed format where you discuss laparotomy, which is now this, it is always been the standard of care. You initially do an abdominal hysterectomy, salpingo-oophorectomy. You have lymph node sampling, which is done, including the iliac lymph nodes, the paraaortic lymph nodes. You have other organs, for example, a liver met, solitary liver mets, which can be debulked or removed. And then the concept of fertility sparing surgery, we have also included. So those young women who are not married or who have not conceived, for them, ovarian cancer and how it is managed. So it's sort of important in these. This is a separate category, so it's important to know how these are managed. And basically now I have also given what my experience is. So now in many centers we practice what is called a sandwich therapy for advanced disease. There is chemotherapy given with internet. It's not always surgery. It is a combination of these, and it has to be individualized based on the genetic basis, malignancy type, histological type, etc. So it's always not just only surgery or only chemotherapy, it is a combination of this. And then you come to prognosis where you have survival rates, you have recurrence rates. So all this is given in a easy table, and it's actually fairly easy to learn. If you look at recurrence 10, 20, 30, 40 to 80 and more than 80%. So it's very easy to learn as far as the stages are concerned. Again, treatment is also easy to learn, surgery and 6 cycles chemo. And you have survival. As you proceed with the stages, it starts dropping. So it's quite easy to learn. Next page. Then after this, we come to certain specific types of ovarian malignancy which are commonly asked. So dysgerminoma is a favorite in certain exams. You have these are all malignant germ cell tumors. So immature teratoma, commonly asked. Again, you have the tumor markers which are specific. So LDH, AFP, beta, HCG are raised. Then you have and all their details, like for example, the chemotherapy, the surgical management are all given here. So yolk sac tumors, another one. Next page. Then you come to germ granulosa cell tumors. You have Sertoli Leydig cell tumors, and you also have Krukenberg's tumors. So all these are all short notes which are seen. These are not some of the most common tumors, ovarian tumors, but yes, they are out there, and one can come across them. So they are frequently asked. Next page. Then we come to the next malignancy, that is carcinoma vulva. And in this, uh, it's important because a lot of the questions and also in theoretical as far even in say a practical scenario, there's always it's not doesn't start with a carcinoma vulva. It starts with a vulval ulcer. What is the differential diagnosis, and then eventually you go to carcinoma vulva. So the book gives a point format of all the differential diagnosis of a vulval ulcer, especially in South Asian scenario. And you have various causes, and of course, one of the least common ones is malignancy, and that is discussed here. So we discuss risk factors, HPV types. You also have HSV, HIV, which are linked. So all these are placed one below the other. You have certain signs like growth, wart-like mass, ulcerative plaques. You have symptoms, bleeding, itching, pruritus, discharge, non-healing ulcer. You have diagnosis. You have the various modalities of diagnosis which are summarized. So it's quite easy to remember, and these can be expanded in the exam. Again, we have a beautiful histopathology image. Squamous cell cancer. You can see the squamous cells here, and this is the typical the cancer in cases of CA vulva. Again, we have divided into type 1 and type 2. There are two types, and it depends on the age group. There are many various, how do you say, features or various ways to differentiate these two types. For example, the age, the focality, the HPV status, or whether it is linked, the risk factors like smoking, immunosuppression, or lichen sclerosis. So very specific things, all high yield facts which are there in case of CA vulva. Next page. We then come to FIGO staging again of CA vulva. You have stage 1, 2, 3, 4, and again you have a substage. So this table actually gives you the location of the stage 1 to 4 and also the substates of 1A, 1B, 3A, 3B, etc. And the details of that of the malignancy. And then you come to lymph node metastasis. You have various types of metastasis and also the spread of these this malignancy. Now, when you come to management of vulva cancer, this is also given. It can either, if it's a local cancer, you can even do wide local excision like is done in stage 1A, or you also have partial vulvectomy. You have stage 2 tumors where you do modified radical vulvectomy (MRV). You have stage 3 where you it actually involves the regional parts or other organs like bladder, anus, urethra. So that has to be resected. One has to get a 2 centimeter free margin. Radical excision involves removal of lymph node and subcute tissue also, bringing the levator ani muscle to prevent an enteroceal. So you have the gracilis muscle flap and something that we do here also in some of the centers. And again, important to know that there is lymphedema, there is can be wound dehiscence, infection. So these are all common complications, and these are given in the textbook. You know, you have n number of things that can go wrong, but it's important to highlight the most important things, especially if you're talking about UGs and PGs and at the lecturer level. You know, it's not, you can get carried away with a lot of information, but it's important to know what commonly happens, because this is what I have personally experienced when by dealing with gynec-oncology. Next page. So even in the surgical treatment, sometimes it can be very daunting to review this. So I've tried to simplify it and filter it down to students, where you have the triple incision method and you have the inguinofemoral lymph node removal. So these two aspects of CA vulva management has been simplified and filtered down uh, for these students. So it's a very clear cut format. You have sentinel lymph node management, which is given. You have exactly where those lymph nodes are: superficial inguinal, deep inguinal, lymph node of Cloquet or Rosenmuller, etc. So, and then the triple incision method as to where those incisions are. So you incise mons pubis in inguinocrural fold, perineum, urethra is excised, labia majora minora is removed. So these aspects are important. Then you come to post-op complications, like you have early, delayed, and long-term. This is very important in CA vulva because women, it's not just about the early complications or maybe slightly delayed like lymphedema, DVT, osteoitis, pubis, etc., but also long-term complications. So they can have hernias, they can have dyspareunia, sexual difficulty. You can have dysmorphism. You can have a psychological depression. You can have psychological trauma. So these are very important and are frequently not written by students in the exam. Now, when you come to indications of radiation therapy, so this is a specific topic as to when you should give radiation therapy in CA vulva. So it's important because, as I said, a lot of these cancers are squamous cell, and it's important to know when radiation therapy and when to operate. So those who are unfit, with stage 4, young women who want to preserve sexual function, recurrent disease, those with stage 3 disease before and after surgery. So all these are very important factors where you give radiation therapy. Again, stage-wise management, you have survival rates. So this is very easy to sort of recollect. If you match the staging column with this, you can solve quite a few difficult multiple choice questions and difficult questions in your exam. Now, next page, if you come to carcinoma cervix, this is something that we see quite often in the rural parts of the country. So again, this is filtered down, and to make it very easy, etiology, histology, and morphology. These are three most important aspects, and this is given first in carcinoma cervix. You have also have the FIGO staging of CA cervix. So you have stage 1, 2, 3, and it's very easy to sort of understand once you know the FIGO staging. So you have a detailed table also which is given, but it's important to highlight the basic understanding or the basic crux of what these three stages are. Now you come to a image which is one of my own cases, which is done where you see the malignancy which is there. Okay, so this is actual clinical scenario and endoscopic images. So important thing to know for UGs and PGs, that endoscopic surgery is also being done. It may not be the mainstay in CA cervix, but yes, there is a lot of trials, lot of investigative trials which are being done for endoscopy. Now you come to the main staging system. So again, you have various groups. You have the substage of these, location of these, and importantly, one thing is given in bold, and that is parametrial invasion. CA cervix, it's very important to know about parametrial invasion. That is why you always do clinical examination in CA cervix. You check for fornicial free, if it is free or not. If it is fixed, then it is stage 2B. Okay, that means parametrium invaded. Even if you are doing a surgery, if you enter either by laparoscopy or by open laparotomy and you find the parametrium is invaded, then the management changes. And that is why this is given in bold. Okay, so next page, please. So again, now on the next page, we have a classical picture of histopath image of squamous cell carcinoma of the cervix. Just as in vulva, you have a very a nice image. It helps to also remember when you have images like this in the exam. You have the various types of spread, again, direct extension to the surrounding organs. You have lymphatic spread, all the important lymph nodes, parametrial, iliac, obturator, sacral, common iliac, paraiotic. Okay, in this order. Okay, so which is the most common versus the least common. So hematogenous spread, important, lungs, liver, and bones. Implantation on the vaginal vault, very important, especially when you're doing operative uh, surgery. Sometimes you can get vault recurrence. Okay. Then the next table below is your various clinical imaging and your samples. You have a table. Uh, what type of scopies can you do? Colposcopy, we start with colposcopy, histoscopy, cystoscopy, proctoscopy. So all these sort of uh, help to look at where the tumor has spread or not. Okay, imaging, which is a non-invasive way, and of course you have clinical parameter, clinical findings or clinical anatomy, that is cervix, vagina, rectum, etc. Now you have prognostic factors of CA cervix, which is also important. You need to know which patients have good 5-year survival rates. So you, for instance, you have stage of cancer, age, grade, lymph node, etc. Next page. Also important is the preclinical and the clinical. So you have these differentiated based on certain parameters like symptoms. Preclinical is always asymptomatic. Clinical is that which is a symptom or it is like the tip of the iceberg. The cervix, which is healthy, you will not in preclinical, so you won't see an apparent carcinoma, but in the clinical stage, it is diseased. You diagnose it incidentally for preclinical, and these are stage 0, 1A, 1B. You know, this is a very early stage. Preclinical is clinical is mainly when there is bleeding, foul smelling discharge. So that is stage 2 onwards. You have a number of other signs, symptoms, complications again, which is summarized in this. Important are the complications. So it can cause renal failure, fistulas, it can cause sepsis, uremia, cachexia, and this is a lot of the reasons why patients die. So one of the commonest ones are hemorrhage and shock, uh, also because of renal infection, renal failure. So all these are given in this table, very easy to learn. Management, again, surgery and radiation therapy. These are both uh, compared in a table. It is quite clear when surgery is done, when radiation is given. What are the benefits or what are the disadvantages of surgery? What are the benefits of radiation therapy? For instance, ovarian function is spared in surgery. Ovarian function can be affected in radiation. So again, staging is accurate in surgery. It is less accurate in radiation. So these are important aspects. Each of these is an important aspect as far as CA cervix is concerned. Then again, the various options and the lymph node positivity rates. Next page. And you have then the type of hysterectomy. So you can have an 1, 2, 3, 4, 5, what they are called, and the important point regarding these hysterectomy. Your pelvic exenteration, when it's done, it's rarely done now in CA cervix. Of course, there is also laparoscopic pelvic exenteration, which can be done. You have primary radiation therapies. The three types are given, what device is used, tandem and colpostat, the time it takes, and the features. So all these are sort of summarized in this table. And then you have an important 2, 3 lines about stump carcinoma, which are specifically asked sometimes um, in practical exams, and you have to include it as when you write a long answer for CA cervix. Again, downstaging of CA cervix, which is extremely important. It has been asked before, and something that students should know, that downstaging offers early screening in areas, especially where these are low, for example, in rural India, which is important, where CA cervix incidence is high. So it basically just explains to you what is a need of doing downstaging. Next page. You also have preventive aspects, which is an extremely important high yield point in CA cervix. What are the primary ways of preventing, secondary ways of preventing, the vaccine? These are commonly asked in Gardasil and Cervarix are the brand names, but you have bivalent, quadrivalent, etc. These are important to know and frequently are given to women in in a lot of urban areas, especially. That is why the low incidence of CA cervix in urban areas, but still there has to be penetration. This is why this is frequently asked in exams. Once this is done, you've covered malignancy. They come to a self-assessment module, which is given. And this consists of long answer questions and short answer questions. So I have framed it. These are some of the most commonly asked, frequently asked, repetitively asked questions on CA cervix, as well as the other cancers. So for instance, you have endometrial cancer, ovarian cancer, staging of cervical cancer, radiation therapy, okay, preventive aspects, and also CA vulva. Then you have these short answer questions like corpus cancer, dysgerminoma, certain other ovarian tumors, surgeries like radical vulvectomy, downstaging of cancer, stump carcinoma, Roma, or some of these indexes which are also asked. So in this way, this is the chapter of gynec malignancy. But it is one of the most high scoring chapters. In fact, that is the reason why gynecology is given before obstetrics in the textbook, because it is very scoring. In fact, most of the answers are very objective, and it is not like obstetrics where you can have different ways of fetus delivering. But in gynec oncology or gynec questions, the answers are very objective and straightforward. So it is something that students must know, and is very high yield. So I think with that, I'll open this for questions or any suggestions.
Thanks, Sai. Sai. I think it's a very, very informative session, and I think you have also very clearly explained the complete chapter and the importance of it, for students and all. Thank you so much. Although we do not have many questions, sir, but there was one question that I got in a feedback itself, which is one of the student wants some information regarding HPV vaccine
Yeah.
at the end of the session.
So HPV vaccine is give they want information as in it is given in the te textbook itself.
Okay,
So
so they still
under
want some
prevention,
information. Yes.
yeah, under prevention of CS cervix, if you read it, there is a detailed explanation of few lines about HPV vaccine. So on who to give, it's important to know it is not just for girls but also for boys. There are two types of HPV vaccine, like I said, quadrivalent, bivalent. The into brackets, if you read the chapter, it is 0, 1, and 6. This is the schedule for the vaccine, and uh, and 0 to 6 is for bivalent. So this basically covers the strains of HPV which are linked to CS cervix. Important to know is that HPV is also linked to genital warts, so you can also prevent that. But apart from that, there are other methods like barrier contraceptives, especially with women with multiple sexual partners, preventing local genital infection because these can be co-carriers. It can also uh, increase a chance of progression to malignancy. Treating pelvic infection immediately can also help. So these are, of course, ways of doing it. Additional ways of course, doing a hysterectomy, removing the cervix. That will, of course, prevent CA cervix. And that is why, especially in high-risk patients, you must do a total hysterectomy, not just a subtotal. So all these scenarios are given. There are, of course, apart from that, a number of multiple choice questions on CS cervix, which are there in the online uh, part of this textbook. So students can access those. Um, and yeah, I think that should answer this question.
Good, sir. So I think we have passed the time now today. Well,
Yeah,
Dr. Sai, thank you so much, sir, for coming up, and discussing the topic, and also that now that books are now available, on e-com sites and as well as the bookstores near the hospitals. So I think it's a must-have for an undergraduate or maybe a postgraduate also to refer to this book. It's based on the latest CBME guidelines. So it's a must for them. And again, sir, what we're gonna do is we're gonna give away 3 books, ebooks access, to the students,
sure.
most engaged students and all. And again, so just for the students, we're gonna have such series because the many other requests have come that we should have some more such series in the future. So we'll have it in the due course of time. Thank you so much for joining us today, sir, and thank you
Thank
all
you.
attending. Thank you, sir.
Thank you.